Hey everyone, hope you're having a good day. Let me know if you can hear me. Hello, Kate. Hey, Jessica. You guys will have to let me know. I've moved my mic around a bit and played with some settings, so if something sounds funky or bad or anything, just good afternoon as well. Hopefully some of you guys get to interact with the interviewees. Hopefully that was fruitful. Sounds the same. That's perfect. Ideal. Got a little bit better placement on my desk. So. Yeah, we'll do the OB-GYN section. I think that's going to be the last one we're going to do for the second test. So I'll mention at the beginning of the class as well. Oh, was the farm assignment doing the wrong Friday? Odd. Maybe Abby? Oh, I think I know what I did there. Okay. Yes, there is method to my madness. I'll start probably like a minute or two. Yeah, we'll get to it. Should pair well with your OB-GYN talks and CMS, I hope. Good afternoon. Boy, this exam on Friday, it's really throwing people for a loop. I feel bad for you guys and gals. Organization for tip. Out to duty. Oh, what a way to bookend your days. You got me at 2:30 and then at 8 o'clock in the morning. My gosh. Sorry about that. Bummer. Hey, Kelly. Of course, the lawnmower people decide to start up right now. Sorry. Sorry, Richard. I don't speak Spanish. A little bit low on your computer. Yeah, I can turn that up a hair. Let's see. I'm gonna futz with the game a little bit, so we'll see. Also, maybe a slight bit further away, so you may just need to turn me up a hair. We'll try that out. No, it's probably I had moved my mic around a bit, so if you guys hear something or want me to adjust something, let me know. Anyway, so let's get started. It's 2:30. So, welcome. Glad you're here. I'll be glad to see you guys tomorrow morning as well. See if we can get a similar turnout. We'll see. Okay, so first thing here, was there any update on the test possibly being moved? I'm nervous about with it being on Friday. I'm very sorry about that. My understanding is it could not be moved due to other issues in the schedule. I believe Alyssa was handling that in her presidential duties. So yeah, that's kind of out of my hands, unfortunately. So that exam is going to be on a Friday. And on a side note, someone said, out of curiosity, why is the farm assignment due this Friday and not next Friday? I did that because exams are normally on Monday, and so I usually try to have you guys finish it on a Friday, so that way you have it the whole weekend. You can just worry about the test and not the assignment. So that's why I did the Friday before, so that way you just get it done. You don't have to think about it for the rest of the week. You can just focus on the exam itself. So that is why I did that. Someone said for the pharm assignment, when it comes to choosing strength for opioids or benzos, is that referring to the dosage forms, or do we calculate doses based off of that, or do we just use the suggested dose based on weight? I would say just figure it out based off of the weight of the patient. In most of your stuff you should be looking up, it should say like fentanyl 1 mic per kilo per hour or something like that. You're using that and then calculating a dose off of that. Unless it's something specific like the type of fluids you're using, you generally don't need to pick like a concentration, like a strength like you would for a typical outpatient script, mainly because we figured that out on our end, right? So if you say something like, I want 500 milligrams of metformin for a patient, and we only have the 250s or something like that, we would just sub it in. We'd just get your order fixed, and you don't have to think about it, right? Similar thing goes on with IVs. Unless you specifically pick a concentration, we'll just sort of default it for you, so you don't have to worry about that necessarily. But I expect you to figure out what the dose should be, especially if it's like a weight-based dose. Figure that out and then put the actual dose on there. So if it's something like if you're writing for Rocephin, for instance, I don't know if that's right or wrong. We'll see. You wouldn't put 50 mg per kilo on there. You would say 1 gram, 2 grams, whatever the actual dose actually calculates out to be. So that's what I would say for that. If you want to put like in parentheses, like 1 mic per kilo per hour, you can do that too. But I expect you to actually put the real dose on there. Someone said for the assignment, would it be appropriate to use morphine as the opioid sedative agent, or would we receive points off because it's not technically a continuously infused drug? Any drug can be continuously infused. Any drug could be intermittently given. It just depends on how you order and what the intent of the order is. I will tell you that morphine drips are not frequently done for sedation purposes. They are certainly done, though, for pain purposes. When you're thinking about sedating someone, and we'll talk more about this like in the surgery and in the more so in like in the, what's the other section? Like the ER section, we talk a little bit about like intubation and stuff. When you're sedating a patient, the goal is to get them to where they're sedated enough to where they can, comply with the ventilator and, not put too much of a fuss, and they're not really cognizant of what's happening because it's a pretty uncomfortable experience. So you want a drug that you can titrate easily in order to achieve a certain level of sedation. And normally nurses have like a protocol for what level of sedation you want to shoot for. And they have different criteria for that. When doing that, having a shorter acting drug allows for easier titration versus a longer acting drug. So if you compare like the half-lives of something like fentanyl versus morphine, you'll get a feel for why we would use something like fentanyl maybe more often than something like morphine for sedation as an example. So, but yeah, we use morphine drips all the time, but it's more so for pain control than it is necessarily for sedation. I'd say it never happens, it's just less likely to happen. So it wouldn't be wrong. You could certainly do that, but as long as it continues infusion, you don't want to, try to give intermittent doses all the time to someone who's sedated, because that would be kind of cumbersome for the nurse to do there. Kind of along that same line there, someone says, should we do a loading dose plus the continuous infusion for the medications? If so, can you show an example how to write that? Just do the continuous infusion. I'm not going to get too crazy with the loading doses. Let me show you what that would look like, though. So I'll use fentanyl because that's kind of the one I'm most used to using. So if you wanted to write for like a bolus, you'd do that as 2 separate orders. You do like a bolus and then the continuous infusion. So you could do something like fentanyl. If the patient, let's say she weighs 50 kilos or something like that, 50 micrograms once PRN sedation, right? So and then you should do IV on there. So you could say that. So fentanyl 50 micrograms IV once PRN sedation. So that would be something like if the patient starts to wake up or something, they start to arouse a little bit, you could do that as a one-time order, right? Alternatively, I could change that around and I could just use that as, say, for instance, Q2 hours PRN sedation. So that way the nurse can go back and do multiple times depending on how the patient is how they're doing basically. Usually when they're intubated, they're getting a big slug of medications to knock them out anyway from a sedation standpoint. So you don't necessarily need to follow up with another bolus dose. So that's why I say just do the continuous infusion. Assume you're the ICU person who's receiving that patient. They're already, they already have been intubated. You should assume they have some medications on board already. Just do the continuous infusion, right? So hopefully that makes a sense. If we have a drug that covers MRSA and a drug that covers Pseudomonas, what else would we need for the prescription assignment? Why should we be adding a third antibiotic? That's a great question. Perhaps you should go back and look at your pulmonology notes and you will see why we do that, right? Think about the patient, past medical history. Think about the conditions of the case, and that may lead you to figure out why you might need another med and to consider which ones you would want to use there. So not to be intentionally vague, but it's part of the learning process. So that's why I do that. Any other questions before we get started here? Thank you for leaving those for me. I like to. Oh, here we go. We haven't started nephrology yet. Is the patient in this assignment renally impaired? Unless I stated so, just assume not. It's fine. Again, I'm just trying to keep it simple. I'm just trying to get you guys the practice. I'm trying to get you guys the practice to actually just writing the orders, right? I'm not trying to complicate things too much, so just assume they are renally okay from that standpoint. Although that is a great concern or consideration to do there. Someone said, do we need a bolus of antibiotics? Don't overcomplicate it. Just do the antibiotic orders. In some cases you may want to do a bolus, but it's very drug dependent. So for instance, like vancomycin, sometimes you'll do a bolus for, sometimes you don't. It just depends on the situation. So I would just say, just leave it off. Just keep it simple. Just do 5 simple orders. I don't want to overcomplicate it for you guys. The whole point is just to get practice writing the orders. Okay. But if you have questions, let me know and I can try to clarify those where appropriate. All right. Let's continue on. That's all the questions on the sticky board. So let's talk about OB-GYN stuff. So I think for the test, because I'm sure that's what you guys are concerned about, we have 3 more class meetings here. So we have today, we have tomorrow, and then I believe Friday. Friday is going to be our review. I am not able to do that one blend flex, but I'm going to plan on doing the next 2 as blend flex, the review. So just FYI on that. And if I choose to do any other ones, I will let you guys know. I think I have a way to do it from a technological standpoint to where I can still get parity with what I'm doing here. So yes, so at least those last 2, if not more, I might try to see how things go and if I can schedule that with the fam and whatnot. But for the test purposes, what we're going to cover for the exam for next Friday, yes, I am going to be on campus for tomorrow, so you'll see me there at the very least. So yeah, if you have questions, then you can certainly pull me aside and do that. So for the exam, we're going to do rheumatology from last section we didn't cover. We'll do ortho and pain management, behavioral health, and then we'll do OB-GYN. Those will be the 4 sections for this exam. Again, that's not like undue burden on you guys because normally I would cover 4 topics anyway. So I think that'll be pretty consistent, and that way, and it'll be evenly split up amongst the categories. So 12 to 13 questions probably from each section, just to keep it fair. Is that right? Is that right? Yeah, it should be 12.5 per section, but so 12 or 13 per thing. So I've not written it yet, but I will do that soon. Okay, so anyway, if you have other questions, let me know and I'll answer those. Let's get into it. I've already wasted 9 minutes of your time. No. So first off, I want to talk about the ladies. Just a brief aside here. I barely have a functional understanding of how ladies operate. I'm still unaware of how I've maintained marriage this long. Let's hope it'll stay for longer. Anyway, getting into first talking about pregnancy and lactation. I like to mention this because, kids are a particularly at-risk population. We want to make sure that when we're giving medications, not necessarily to them, but to the moms, how that may have some ramifications for them. And so I'll talk about some sort of, landmark sort of examples of this where it was certainly a big deal, and, ways we can try to avoid this if at all possible. Back in the late 50s, early 60s, there's a drug called thalidomide, which you guys may have heard of this before. It's actually used as an anxiolytic for women with pregnancy and some activity for nausea, vomiting. They realized though that when these babies were born, they're having like malformations of their limbs. You can see here they have these like kind of underdeveloped upper extremities, kind of like flipper-like appendages. They describe them, and so fortunately, I don't know that there are any documented cases in the U.S., or if there were, they were quite small. Thalidomide was not widely used in the U.S. at the time, although we still use it very occasionally. It's more so for certain oncologic purposes, which I'm not going to get into. But because of that, we saw what happened over in the UK. We decided that, yeah, we should probably have some kind of law that says, yeah, we should make sure that drugs are safe for pregnancy before we just start giving them willy-nilly to pregnant patients. And so that was where we got this amendment to the Food, Drug, and Cosmetic Act. That's the main act that sort of governs how we handle food, drugs, and cosmetics. And it seems like, oh, it's smattering, but yeah, the same laws that dictate how we do drugs also apply to cosmetics in some ways. And anyway, this data is a little bit old, as you can tell, but certainly we're seeing kind of an uptick in the number of medications that pregnant women are using. Either women are continuing chronic medications that they were on beforehand that have been deemed medically necessary, or they are being prescribed medications during pregnancy for various conditions, which we'll get into a few of those here. Ideally, you'd like to treat pregnant patients with no medications because that's the safest thing for a developing fetus, would be no drug exposure. However, that's not really feasible in many cases. And again, typically speaking, the first trimester is really the most important part of development for a fetus. And you're going to see sort of the most dramatic effects in terms of fetal development where drugs can have a negative impact. As an example, when we talked about valproic acid causing neural tube defects, that's a problem in the initial development of the child when you're actually having a neural tube being formed. It would probably be less of an issue if it was, say, taken in the third trimester as an example. But yeah, so you're certainly going to be dealing with women who are pregnant who are taking medications, and so it's important to try to understand how they're being used, if it's appropriate, if it's not, or if there may be alternatives we could use instead, right? You'll see a lot of OTC medication use. It's important to make sure you ask about over-the-counter medication use, ask about herbal supplements, dietary supplements. All that stuff is important to capture because any of it could have an impact on that developing fetus. But you can see here some sort of the most common ones. But certainly that we're going to be seeing more and more antidepressant use. Because again, if someone had a legit issue where they needed to be on an antidepressant, and all of a sudden it's like, okay, you're pregnant now, let's take that away. That can be a bit of a challenge for that patient. So you're seeing more and more use during pregnancy there. It's a challenge because I think a lot of pregnant women have a lot of mommy guilt, for lack of a better term. And so they want to have as little drug exposure. And you'll run into patients like that who they vehemently deny taking anything or will deny receiving anything on account of it could have a negative consequence. Because again, when you're looking at statistics, you can say, well, this is like a less than 1% chance this will happen. But if it happens to your kid, it happened. And so that's a big deal for them. So anyway, some definitions here include things like teratogenesis, which is basically any significant sort of change in form or function due to prenatal treatment with the medication. This can include things like congenital anomalies, like malformations. You can see congenital heart defects that can happen here. We saw the limb thing that was happening with thalidomide and all of that, and then congenital malformations that actually deal with more so like the viability or the physical well-being of the child after being born there. So not great stuff. And just as an example of like known teratogens, we've covered many of these already that are big no-nos in terms of use during pregnancy. So things like ACE inhibitors, things like isotretinoin, we've talked about pretty extensively when we say this is a category X drug. Now we're getting some of the context for that. Certainly cigarette smoking, cocaine. But again, it could be really difficult for patients either to stop doing these, these substances once pregnant, or they may be using them before they even realize they're pregnant. Again, it'd be nice if there's like a big light bulb that went off that said, guess what, you're pregnant as soon as conception happened. But unfortunately, that is not the world we live in. So how do we know if things are teratogenic? Can we take like 1,000 pregnant women and put 500 of them into a placebo group and 500 into a drug treatment group and see which babies come out with abnormalities? That that's likely a sticking point for a lot of ethical people. So we don't do that, right? And so that's part of things like institutional review boards and things like that. They'll look at the ethics of a study, and it's really difficult to get good evidence for drug effects on pregnant women because you can't do those studies. You can't do randomized controlled trials, right? So how do we find out? Well, we could do things like animal studies, right? So poor animals, of course, but you could potentially see what effects that drugs will have, like on the development of a mouse fetus, for instance. Now, is that 100% generalizable to humans? Not necessarily, but you may be able to take away some features there, right? We're both mammals. However, a lot of information comes from things like case reports, where maybe women might have just happened to have been on these medications, and then they report, or their providers will report out on what happened to those particular pregnancies. You could do things like case control studies or cohort studies. These would obviously not be things where you're like recruiting for them. It would be more so things where, you're maybe using retrospective data for a lot of case control studies, for example. And then we also have like voluntary reporting systems. So if you ever have a patient who's pregnant that develops some sort of drug related, or even if you don't know, if you just think it may be drug related, you can still report that, and they'll do the investigation to try to figure out if that was actually there's a relationship there, right? Remember, correlation is not causation, but they have means of trying to figure that out. And so, of course, the blanket disclaimer is like, well, don't use this unless you think that the benefits could outweigh the risk. And there are rare cases where a drug is absolutely mandated to where, yeah, we know it has documented harm to a fetus, but it's medically necessary in the adult, such that, if you lose the mom, you lose the kid too, so to speak. But those instances are quite rare, as we're going to see here. And just as an example of trying to show you how important that first trimester is, it's during that organogenesis when really the most critical periods are happening, where drugs can have the greatest effects. So, valproic acid and neural tube defects, as I mentioned there. Later on, though, you can certainly see other factors that come into play. Like, so for instance, NSAIDs go from, they will actually change category depending on what trimester the patient's in. It actually gets more dangerous towards the end of pregnancy as opposed to the beginning, which seems kind of counterintuitive until you know kind of the mechanism behind that. But so great segue into my next slide. So like NSAIDs, as I mentioned, has a tendency, basically when a fetus is still a fetus and they're in the mom, they have the ductus arteriosus, which maintains normal fetal blood flow, and that's opened with prostaglandins. And so if you lose that early by giving something that blocks production of prostaglandins, that can close early, right? So you can have premature closure of the ductus arteriosus, and that can lead to all kinds of issues in terms of fetal blood flow, because they're not breathing yet, right? So they don't really need their lungs working if they're still in the mom. Route of administration can sometimes make a difference here in terms of exposure. Obviously, certain medications when taken orally don't have a ton of oral bioavailability, and that can maybe be really good because you get less systemic exposure to the mom and then subsequently to the fetus. And then certainly dose, duration, etc. The more exposure, the bigger dose exposure you have, the more effects it's going to have on the fetus, obviously. So in the changes can be very wide. They can vary quite wildly. Whether it's destruction of the fetus. So for instance, if you were to give a pregnant patient misoprostol and methotrexate, like that can cause a chemical abortion, basically, right? So that's destruction of the fetus, whether that was the intent or not. Things like CNS abnormalities, structural anomalies, all kinds of negative things can happen here, right? So that's why we say, fewer drugs, the better. But let's talk about some of the principles that go into deciding, like, how, what's the things that cause fetal drug exposure. Not every medication you take is going to be presented to the fetus in a one-to-one sort of concentration as the mom, because there are some protective barriers there that help prevent this. So as an example, to get back into the pharmacokinetics of absorption, you thought we left that all behind, I bet. But you can see here things like lipid solubility make a difference. So if they're more lipid soluble, they can cross the placenta more easily. If things have a positive charge on them or negative charge, they can't cross very well. Actually, interestingly enough, you can find that certain things can undergo what we call ion trapping. That's basically where if a drug transitions from one solution over into another that has a different pH, it can develop a charge. and get stuck there on that side. So for instance, if you had something like a weak base, for instance, that was, relatively unionized in the blood, and then it crossed over into the placenta, and then all of a sudden it gets into a more acidic medium, and then all of a sudden it gets more so trapped there, so it can concentrate in those cases. We'll see that comes up again with lactation as well in just a little bit here. And then just the molecular weight of the drug itself. Some molecules are very small, so they can cross very easily. Some things are quite large, and they're unable to do that. So like protein-based drugs don't have a tendency to cross over very well just because they're very large. Vancomycin, for instance, cannot cross over because it's a very large molecule. And you can look up structures and get an idea for that, but I'm not going to necessarily bore you any further than what I already intend to. And then protein binding as well. If things are extensively protein bound in the mom's serum, it's going to have a harder time crossing over into the across the placenta there. Okay? So little features that they can factor into that. Another thing to consider too is that the placenta, itself is sort of a semi-permeable barrier, so it does provide some protection there, but there's also a little bit of drug metabolism that can happen by the placenta itself. So you can actually get some drugs being kind of detoxified, so to speak, from that way. Otherwise, drugs are going to basically enter in, though, through the umbilical vein. This is where most of the blood flow is going to come. However, the benefit of this is that most of that blood flow actually goes to the liver. So even though they have an underdeveloped liver and they're not going to be expressing CYP enzymes like adults might, they can still have some drug metabolism there. They can help to limit exposure. So kind of a nice design there from a physiologic sort of standpoint. So that goes into the categories. When we're trying to categorize drugs and saying like, well, how safe are these or how safe are they not? We're starting to move away from this mantra of this A, B, C, D sort of category, because I think it kind of puts it kind of simplifies it too much. If you see, okay, well, everything's an A, everything's a B, that's great because that's very safe, right? It's when you get to the other letters where things get a little bit more worrisome or troubling, and one in particular. But if something is an A or B, pretty much safe to give to pregnant patients. I would feel totally comfortable giving it to a family member or my wife if she was pregnant, Lord forbid. I would feel totally comfortable giving A or B because we either have evidence of maybe case reports or studies that have been done that show no demonstrable harm to fetuses, or in some cases we may have animal studies that don't indicate any risk, and then also we don't have any human data that would show that. Or there may be some rare cases where animal studies do indicate risk, but we have enough human data to show that it does not cause any harm. Right, so some of these things might be kind of like, so to speak, grandfathered in, where we were using these drugs for decades in these pregnant patients, and it wasn't until we kind of looked retrospectively to see, okay, well, was there harm, right? When you have that kind of data, that can kind of clue you in a little bit to whether you can associate that kind of harm or not, right? Someone was saying, just to clarify, a drug with a lower pH will more easily affect a fetus. You will see easier crossing of it, right? So if it was something like a more weakly acidic drug, it would be able to cross over, and even in the fetal pH would be a little bit lower, so it would be more in an unionized state, cross back over. It was saying that like a weak base or something may cross over, but then it develops that charge now that it's in a more acidic medium, and then we'll have a harder time. It'll just bounce back against that placenta and can't get out. So that's why you can see some drugs will concentrate in certain tissues or certain areas because of that ion trapping. I'll show you another example of that when we talk about breastfeeding here in just a moment. But so A or B, very safe, right? C is kind of like the junk drawer. I don't know if you guys have like a junk drawer in your house where like old electronics go and batteries and just whatever just gets shoved into there. That's going to be category C because we don't really have a good idea of whether or not it's going to be a harm to the patient. We don't really know if it's safe. So it's very much a risk versus benefit sort of analysis. Problem with this is that like the majority of drugs just got lumped into category C. So you as a provider would look at that and say, well, should I use this in my pregnant patient? It says C. That's all it said. That doesn't tell you anything. So I'll show you the new way that we can kind of parse that out, and it gets more difficult than just looking at a letter. The letters are nice and easy, but C is unfortunately applied to many of them, and it wasn't all that clinically useful. Marley's saying, is there a change in safety for A or B based on gestational age, or if they're deemed safe all throughout all of pregnancy? Your drug references should indicate that. They'll tell you whether or not it changes, and I can show you an example here in just a little bit. I'll go ahead and get one keyed up for you here in just a second. But it can change, and it will tell you that if you're looking at like a reputable source. Now, category D here, D and X are basically going to be like just avoid if at all possible for your patients, because you're basically going to see a lot of issues with that. I'm just find pregnancy categories here. See, like even Lexicomp is trying to move away from it, so I'm not showing it to you right now, but I'll get to it in a second. But yeah, you may see that it changes. So something could be like a B throughout like the early stages of pregnancy and then turn into a D later on, for instance. But those are relatively rare. But anyway, when you're looking at a category D, this is going to be the situation where we know there's demonstrable harm to a fetus. However, there could be situations in which giving it to the mom would outweigh the risks. Again, those situations are very far and few you'd run into. So for instance, I think like Warfarin still carries a category D, right? Even though we know it can cause fetal harm because it causes bleeding. But nowadays you'd never give Warfarin to a pregnant patient because we have better means of anticoagulating them if they needed it. We have newer drugs that can serve that role, replace the role of Warfarin basically. So very, very unlikely you would ever give a category D drug to a pregnant patient. And then category X is like there's absolutely no benefit to giving it to the mom that outweighs the risk that it does to the fetus, right? So like someone throwing a clot and having a stroke because they're not anticoagulated, that you could make a case for someone getting something like Warfarin, even though it can cause harm to the fetus. But you know, if someone has acne and they want their isotretinoin, that's a harder sell, and I don't think anyone would necessarily say that benefit outweighs the risk, right? So anyways, that's how things kind of got lumped together. Let me talk about breastfeeding real quick, and I'll show you kind of the new way that we sort of categorize. I think I have it here. Yeah, okay, so I'll show you guys in a second. Same things kind of apply to breastfeeding in terms of like transfer into breast milk. So things that have like higher lipid solubility are able to cross over more easily. As I mentioned, you can have ion trapping, or drugs will concentrate in the breast milk, and so that'll have an effect on once the infant is born in terms of continued drug exposure. So as an example, I talked about that NICU kiddo whose mom was taking an SSRI throughout pregnancy, but the kid gets born, is not really flying solo on their own too well, so they get put into the NICU. Now they may not be really getting a whole lot of feedings from mom necessarily, and so now all of a sudden their source of SSRI was cut off, and they started going through withdrawal. Breastfeeding can kind of help ameliorate that because now you're still getting continued exposure of the drug through the breast milk to the infant, right? So that's a means of trying to continue that exposure, but may not always be clinically feasible in some cases. But same factors apply to placental transfer as it does into the breast milk, right? And that's why you always hear about women who will do things like they pump and dump, especially if they want to have exposures to certain substances. I think alcohol is probably the most common one you think of, to where, you know, if a mom wanted to have a drink, she could then take that milk that was then produced and then dump it because it presumably has some alcohol in it. And then once the alcohol is out of the system, then the breast milk that is then formed will not have any alcohol in it as well. You know, there's like little test kits and things like that. And I do not begrudge any pregnant or a recently pregnant mom wanting to drink, because boy, having a newborn is something else. Can certainly drive a person to drink, I imagine. Interestingly though, you actually find that time since delivery can actually have a role to play here, although clinically I don't know if this comes up too frequently. But you can actually find that soon after delivery, for like the first 2 weeks postpartum, there's actually larger gaps in the alveolar cells, so they're actually able to get more crossing over of drugs, even things that might not cross over so easily 2 weeks later, you know. And then again, the major determinant here, though, is maternal serum concentration. So going back to the alcohol example, if mom has one drink, let's say one glass of wine, fetus may get certain exposure. If they have the whole bottle of wine, they'll get a much higher exposure. So that is an important consideration as well. But that's why you can kind of strategically schedule those feedings, do the pump and dump sort of method there. And again, you can see the pH of the breast milk can kind of change pretty widely there, and that can lead to some of that concentration of drugs due to the ion trapping effect. But again, I'm not going to get into specific examples because it doesn't really come up all that frequently. And again, you can look stuff up, which I encourage you to do. So this kind of goes into the pregnancy label changes. This has been in effect for some time now, but I think it's good to sort of show you this. So especially if you're looking at old references, or if you hear providers talking about this in sort of the old way of doing things, it used to just be basically, you know, the current labeling at the time would have like a pregnancy section, have anything that could affect labor and delivery, and then for nursing moms, right? Now we basically say, okay, well, let's break it up and make it more kind of more inclusive. Basically, labor and delivery and during the pregnancy is all included in one section. You'll have a section just on lactation, and then you'll have issues that may pop up with both males and females of reproductive potential. So you always hear me say of like, oh, if a person of reproductive potential, right? You know, that doesn't necessarily kind of peg anyone to a specific example of like age or anything like that. It just says, okay, are you capable of reproducing? Yeah, this drug could then affect you potentially. That's why, for instance, like males getting isotretinoin could still potentially affect a woman or someone who has gotten pregnant, right? Someone with the uterus has gotten pregnant. So anyway, so and that includes things like, you know, effects with contraception, pregnancy testing, etc. Right? So just to give you an example of what this would look like. So for instance, here's Warfarin. Sorry if it's a little small, you can try to expand it out. I'm not gonna get into all these details here, but here's like what it used to look like. It would just say D and then maybe X for other indications. So if the mom had a mechanical heart valve, there was a way you could say, okay, well, maybe the risk is, you know, outweighed by the potential benefits, because the mom throws a stroke, you know, throws a clot, gets a stroke, she's going to die. The fetus is going to die too. But you know, for any other indication to be X, and then it actually goes into the details. It'll actually tell you specifically what happens, and this is kind of the secret sauce here. This is actually where you get the information to be able to decide, do the benefits outweigh the risk in my particular patient specifically, right? And you may not be able to come to a you know, the best answer, but you can at least look at the data and see what's present there. Another example would be something like Ondansetron, which has a pregnancy category of B, meaning it's relatively safe. Doesn't mean that there is no risk of harm. It just means that it's relatively low based on the evidence that we have. And it's nice here because it'll sit there and tell you specifically what it is, right? Now, some providers might just look at that B and say, okay, it's good for my patient. But you, as very astute providers, are going to look into the details. You want to get into the nitty gritty of things and figure out, okay, is this really going to affect my patient or not? Based on maybe they have a history of QT prolongation. I don't know. You should check that out. And that's important. And this is information you're not going to get just by looking at the pregnancy category. Okay. Same thing for breastfeeding considerations as well. So hopefully that makes some sense. So now getting into treating different conditions for pregnant patients, you're going to see here that there's a lot of physiologic changes that occur in pregnant females or pregnant women, and you're going to see that some of the issues they run into as a result of some of these physiologic changes, right? So for instance, when they develop a lot of nausea, vomiting, or they develop gastric reflux, some of it may be just due to the physical changes they're undergoing here. So it's good to understand kind of what's happening, and especially some changes like in hormones and all of that can have some big things to play in terms of what conditions we might need to manage, right? So anyway, I think I lost my thing. Oh, someone said, can you explain ion trapping again? I do not understand. Okay, so let me see. Let me open up Microsoft Paint. Let me do some old school drawing. I haven't done that for you guys in a while, right? Okay, so let's say we have a barrier. You guys can see that, right? Yep, you can see that. Let's say you have mom over here. And then you have the fetus over here. I'm just use that for fetus. So if you have, say, a drug molecule sitting right here, and let's say that it's not charged, it's a neutral molecule. If it crosses over here, and let's say this is a weak acid, in this case, right? So if this crosses over into the placenta, or crosses the placenta here, you're going to see that the pH may be a little bit lower. So lower pH. I know the pH should be little, but that's okay. So lower pH. That's okay because this is going to stay in an uncharged state and it can cross back over relatively easily. This can cross freely. What's going to happen though if you have something like a weak base and it crosses over here where it has a lower pH, what you're going to find is it's going to be developing a lower pH here. You're going to find it gets stripped of its extra proton. It's going to become more of a positive charge, right? So because of that, as weak base is positive charge, it's going to bounce against this. So it's not going to be able to cross back over. And so it's going to be stuck here basically. So this cannot happen. And the drug will accumulate and just get a bunch of it sitting here. And more of that's able to affect the fetus basically, right? So remember, like dissolves like. And you have a weak acid, and if it's a lower pH, it's okay. It can still cross over. It's because it doesn't get charged. But a weak base is going to pick up that extra proton and be in that positively charged state, right? So that's sort of the difference. So drug concentrates when it goes into a pH that it's not soluble in. If that makes a sense. Again, behold my art. It is beautiful as well as terrifying. If that doesn't explain it, let me know. I can try to get more into detail. Someone says, can you still get sued if your patient / fetus ends up dying through got the idea of like a fetus walking into a lawyer's office to sue someone? That kind of cracked me up. Ends up dying through taking category D drug, even though you thought the benefits outweighed the risk. A lot of that comes into like getting consent from the patient too, right? So all of that is part of, just like, you know, if you took someone to surgery and they died without you explaining the risk to them and they did not consent to that, yeah, you can get in big trouble. So if I was to recommend a medication, or if someone's to order a medication for a pregnant patient, you'd want them to know the risk. And you should do it with any medication, right? You should always tell them the side effects they can experience and let them make a decision on whether or not that's an appropriate med for them in particular. So yes, you should definitely have that documented. I'll give you a really good example of where we really wanted to cover our butts, the CYB, I guess. We had a patient who came in who was a snake handler. He was an amateur snake handler, and he got bitten by, I believe it was an Egyptian cobra. Now, I don't know if you guys know this, but Egyptian cobras not really endemic to the U.S. Okay, so we don't really carry anti-venom against Egyptian cobras because they just don't live here, right? So we ended up having to go to the zoo. I think it sounds silly, but we go to the zoo because the zoo has to carry anti-venom for all the snakes that they have, any venomous reptiles and things. And so it's a non-FDA approved product because, again, we don't have these snakes here. So why would they approve something for an Egyptian cobra when we're in the US? So we had to grab that, and so basically take it back to the patient and be like, listen, this is a non-FDA approved drug here. There are risks associated with this. You could undergo anaphylaxis. You could have, this has not been maintained at a pharmacy. It's been maintained at the zoo, but they tell us they've been storing it correctly. All that kind of stuff. Go through all the risks and say, would you like to receive this? And they have to consent to that and sign it. And so that way we're able to cover ourselves. Now, if that person had maybe undergone respiratory paralysis from the venom, was not able to consent, then maybe a family member could, or, there's ways to go about that. But yes, consent is super, super important for anything you do. Meds, surgery, snake venom, anti-venom, otherwise. Anyway, hope that makes sense. So what are the changes that occur typically during pregnancy? You're going to see that the changes certainly begin during the first trimester. They kind of peak around the second, but you'll see things like blood volume goes up quite significantly because now you're pumping blood for 2. And so you can see cases where you have like kind of sludging of the blood because the red blood cell count's going up. So that can lead to some issues from a clotting standpoint, as we'll see here in a little bit. You see things like renal blood flow is going to go up, cardiac output's going to go up. Ideally, blood pressure will remain consistent, but you'll certainly see increases in heart rate. So these are things you'll be looking at. And again, consider what their past medical history is. Perhaps some of those can be aggravating some of these changes here, like if they had hypertension beforehand, right? You're going to see things like decreased GI motility, which will lead to a lot of the GI effects you'll see during pregnancy. They'll be in a hypercoagulable state. I'll talk about why that is a little bit later, but it has to do with estrogen, increasing production of clotting factors. They may have decreased albumin, so that way they have increased volume of distribution for protein-bound drugs, right? So if you have less albumin, drugs that are normally highly protein-bound are going to be more free to kind of go where they will in the tissue, so that could be an issue. And then certainly we're going to see some weight gain. Some of this will be body fat, and so that may affect things like fat soluble medications. They may have more room to distribute out into that depending on just how much weight the patient may put on during this time. So drug selection in pregnancy, ideally avoid where possible, right? So again, I know I'm getting myself losing job security by telling you that, but that's the secret, is that most patients, if you can use fewer drugs, that's probably good. So do that. But you may need to consider what acute and chronic conditions you're dealing with as well. So, for instance, if they had high blood pressure before pregnancy, you probably still have to deal with that during pregnancy as well, because it's only going to be aggravated typically by pregnancy, right? And so, ideally, if we can identify medication use prior to conception, that would be great, especially if you have a patient who is like planning out becoming pregnant and they can kind of prepare for all that stuff, that would be good. And then they can eliminate non essential medications if at all possible. So, kind of figure out going through the list. They take OTC stuff, dietary supplement stuff, try to get rid of the stuff they can that's extraneous. And then discourage self medication. So, just at least have them call you, have a conversation, figure out, hey, am I okay to take this med or not? Would be good to do as well. And if we have to use harmful meds, try to use a dose or a route of exposure or a dosage form that's going to limit exposure to the fetus. That's the goal there. So we're going to try to minimize systemic exposure of these medications, because less systemic exposure to the pregnant patient, less exposure to the fetus. Okay. So here are a couple of things we're going to run into. Notice a lot of this is going to be GI related. So fortunately, we've talked about a lot of these already, and then we'll get into a few other things like gestational diabetes and hypertension and coagulation issues as well. So first off, for nausea and vomiting, what can we do for these patients here? Some of this could be helped with dietary changes. You'll find some pregnant patients may have changes in their sense of smell, to where certain things maybe they're more sensitive to, than they were before pregnancy. So if you can try to avoid some of those triggering foods, that can be beneficial. Certain things you could give that are considered relatively safe include things like pyridoxine and doxylamine. And you're thinking like, we didn't cover those in terms of antiemetic use before. That's okay, because this does make a little bit of a sense. Pyridoxine, I'm not really sure why that decreases nausea and vomiting in pregnant patients, but pyridoxine is B6. It's a water-soluble vitamin. I mean, that's safe for anyone to take, right? So that makes sense. It's an A. Doxylamine, this is a first-generation H1 antagonist that we did talk about previously, probably back in ENT. And this is one that you'll see frequently recommended for sleep, more often than not. If you see the over-the-counter variety called Unisom, that's doxylamine, which makes sense because these drugs will be sedating. So this could be a good thing. We actually can use the combination of the two. And in fact, there's a drug product called Diclegis, which is a combo product. However, it is more expensive than if you were just to buy over-the-counter pyridoxine and doxylamine. So if this was a concern in terms of price for your patient, I would probably just say go buy this over the counter, and you'll probably get similar effects, as a Diclegis. Other options that could be relatively safe include things like metoclopramide and promethazine. Keep in mind though, there are sedating. So if this pregnant patient needs to go to work and be, with it and cognizant, maybe this is not good if she's, they're going to be extra sleepy while there. Also remember that these can antagonize dopamine receptors, so you can run into those extrapyramidal side effects. However, things like Ondansetron going to be relatively safe here. So those are category B. A little more expensive. Again, they're prescription only. So, but that would probably be my best bet. If the doxylamine and pyridoxine did not work, I'd probably go with one of the Ondansetron most often. So we don't necessarily have a ton of information as compared to something like doxylamine that's been around for forever, or pyridoxine, which has literally been around for forever. But again, we talked more about that in GI. Just remember QT effects you'd want to be watching out for if that was a concern for your particular patient. So next, for heartburn, if we can do maybe more frequent, smaller meals, that can be useful. Keep in mind, especially as pregnancy develops, you're going to be having more and more pressure kind of up against your diaphragm, which can lead to some pressure up against the stomach, which can cause reflux to occur. So, when this happens, you can use things like antacids. I would say use them in moderation. Especially, I would avoid the sodium containing products. I probably wouldn't want to use something like sodium bicarb because we do know that can be more salt retentive and can exacerbate hypertension. So these patients will also tend to have swelling, especially the lower extremities, just due to extra blood volume. Extra salt's gonna make that worse as well. So I'd probably avoid salt containing stuff. But remember, like if your patient's constipated, like calcium carbonate is gonna worsen that. Okay, so it's kind of a double-edged sword there. You kind of have to take the good with the bad. Carafate can be used. It's not really absorbed systemically, so that's relatively safe. However, I think H2 blockers and proton pump inhibitors, they have pretty good evidence, I think, for safe use in pregnancy. I'd probably go with an H2 blocker first if you can. And again, I get rid of this ranitidine because that's no longer available. But something like Pepsid, I think, would be good to go with just because it has a longer track record than something like a PPI. They'll probably use those as like a fallback if the H2 blockers failed. For constipation, biggest thing would be to non-pharmacologically increase fiber and water intake. That would be good. Some moderate exercise would be good. Not saying to like go run a marathon or anything, but just moderate, get up and get around. We like bulk forming laxatives here because they don't get absorbed. So no systemic exposure to the fetus, which is good from that standpoint. So things like methylcellulose and psyllium husk are good there. Docusate, good to use. They say it's a C, although I don't really see much systemic exposure to this, but I have seen that used with some regularity, so you could do that too if you wanted. And then things like polyethylene glycol are also going to have some limited utility here. Again, this one's not been around for as long, the Miralax, so it may not have as strong of a recommendation, but it's probably pretty safe to use for your patients that are pregnant there. So maybe even like a capful of that a day would be perfectly reasonable for a pregnant patient. Marley's saying, when I was working in the ER, there was a time period for a few years ago where they stopped giving Ondansetron to pregnant patients. Was there an issue with it at some point? Not that I'm completely familiar with. As far as I know, it's still safe to use. It may have had to do with something with like the QT prolongation effects. There was some concerns around that. Let's see. Yeah, I'm not really seeing any issues with it. I'm looking up on Lexicomp here, so I would feel comfortable giving it to a pregnant patient. But again, everyone needs to kind of take this with their own, discuss it with the patient to feel like see what they're comfortable with or uncomfortable with. Not everyone is going to feel comfortable taking medications just because they're having something. They'll just want to maybe soldier through it in some cases, which is not great. I can't spell occasionally very well, but that's all right. I'd probably avoid using stimulant laxatives unless it's on a very occasional basis. And then, sometimes things like mineral oil, I don't see a lot of people using that nowadays, but could have some issues because it may bind up fat soluble vitamins, and you need fat soluble vitamins for healthy fetal development. So I'd probably avoid that if possible. So, fiber, A-OK, stool softeners, osmotic laxatives for limited use, those are pretty reasonable. And I'd say stimulants only if absolutely necessary. For hemorrhoids, the biggest thing you can do for here is if you try to avoid constipation. That's the biggest way you can kind of stop that from occurring there. A lot of the products that we have are basically going to be basically trying to decrease the inflammation of those veins when they get really inflamed and engorged. So things like preparation H. Preparations A through G just were non-starters, did not work very well, but preparation H actually worked quite well. Just kidding. But you'll typically find like hydrocortisone is used in preparation H as a means of decreasing inflammation, so that helps to decrease some kind of the pain and the irritation with that. And then phenylephrines in a lot of those products too, because it acts as a vasoconstrictor, so it helps to kind of squeeze down on that vessel and help to eliminate that if possible. Tux pads are sometimes used, which are basically witch hazel. Those are okay. It works as an astringent, so it kind of like tightens up that epithelia to try to shrink it. That's fine, and sitz baths can be also useful here. But the biggest thing is just to avoid constipation if at all possible. For diarrhea, I do stool bulking agents primarily, so you can do things like psyllium husk and whatnot. Loperamide does have a B recommendation here. It does work perfectly on those GI opioid receptors, so it's not like you're going to see opioid effects on the fetus. But again, I'd probably hold off on this unless necessary. If you can utilize the bulk forming laxatives first, that's probably going to be better from a systemic exposure standpoint. All right, so moving on so again, that's such fairly simple in terms of the GI stuff there, because not a lot of those drugs are really going to be problematic from a pregnancy standpoint, which is handy. Now let's talk about pregnancy-induced hypertension. Certainly this is going to be something you run into with patients who have pre-existing hypertension, or they can develop it during pregnancy. It's where they can develop like preeclampsia, where they start to spill protein to the urine. And it is relatively common there, and it can develop all the way into full-on eclampsia where they get tonic-clonic seizures associated with this. So it can be quite severe. You can find there's hepatic issues that come about with this as well. So not great. So you really want to help to get that blood pressure under control as best as possible. However, there's some challenges with our blood pressure medications we're going to see here. So what are some ways we can do this? One, you could try to restrict activity, and so bed rest could be recommended here. However, consider that your patient's also hypercoagulable due to all the estrogen that they're producing, and so that could put them at risk for VTE. So again, double-edged sword there. Could try to do things like stress reduction. I tend to find that removal of the husband from the situation, if that is feasible, does help out with stress reduction in a lot of cases. I've been kicked out of lots of rooms when my wife was pregnant. And then some mild exercise can help out with that as well. It's actually been found that calcium has some help to decrease risk of hypertension and preeclampsia. So maybe calcium could be useful. However, remember that is constipating, so may not be great from that standpoint. Actually, what's really interesting though is that like for true eclampsia and preeclampsia, we actually use a lot of magnesium sulfate once they actually come into um, the OB wards, right? So we actually use a ton of IV magnesium sulfate. It kind of works like a natural calcium channel blocker. So similar to like asthma, where we talked about magnesium relaxing the bronchial smooth muscle, this can kind of do the same thing on the blood vessels too. And in fact, one of the concerns when you give like big boluses of magnesium sulfate to people IV is you can bottom out their pressure, right? So we typically will give it with fluids, say if someone had status asthmaticus, for example. We'll give them with some fluids to help prevent that bottoming out by increasing their blood volume, basically. However, you'll probably not see any more cavalier use of magnesium than in a labor and delivery ward or in the OB ward because of the fact that they will give huge doses. Like I think most max doses of magnesium, even for people who are like in cardiac arrest that are going to get like 2 grams, they will give like 4 to 6 grams over like 20-15 minutes. Like huge doses given very quickly, and then they'll give them another 2 grams per hour as it continues infusion. So a lot of magnesium. Not that I'm going to ask you the dose on the test or anything, but just know you're giving like pretty big doses here to try to get that blood pressure under control. If they're seizing from this, just like I mentioned before, just like with infantile seizures, you don't treat infantile seizures with anti-seizure meds, you treat them with antipyretics. Or febrile seizure, I should say. Let me correct that. Febrile seizure, you do not treat with anti-epileptics, you treat with antipyretics. Same thing here. You want to treat the blood pressure because that's the issue here. Things like benzodiazepines and phenytoin, we know those to be teratogenic, so that's why we avoid those for those patients there. So we don't want to have any drug exposure to the fetus if at all possible. Now, for chronic management, you don't want to send your patient home on a magnesium drip. That would be impractical. We have a few options here. The old school thing we used to do would be methyl dopa. It's a drug I didn't mention before because it doesn't get a lot of use clinically, but this used to be the previous drug of choice and kind of worked a lot like clonidine and guanfacine does. If you recall, those are alpha 2 agonists, and so basically those will decrease sympathetic outflow by activating some of those autoreceptors to decrease release of norepinephrine and things like that. So overall, those can help lower blood pressure, lower heart rate. Again, maybe a little bit of sedating there. Nowadays, I see a lot more use of things like labetalol, which is a nice third-gen beta blocker that also has like some alpha blocking capability. So it's able to block alpha 1 and can reduce blood pressure somewhat from that mechanism specifically. So that's good for like throughout the pregnancy. You could use it also like in the hospital setting for acute management because there's IV forms available. So pretty good drug for either chronic or acute use in these patients here. Other things we've tried as well include things like calcium channel blockers, primarily dihydropyridines, you'll see there. And then for like really rapid IV treatment, occasionally may get things like nitroprusside or nitroglycerin. But ideally, I think most people probably go with labetalol in a lot of those cases or magnesium. If you're at that point where you're trying to consider, nitroglycerin or something, they've probably already gone through, the magnesium and labetalol at that point. How about gestational diabetes? How would you manage that? This is basically any degree of glucose intolerance that's recognized during that pregnancy and is, again, can be much more common in patients with pre-existing diabetes, obviously. And usually you're going to find if this is like a new finding for these patients, it will resolve after the pregnancy, but they tend to be a higher risk for type 2 diabetes down the line. And we're going to talk about endocrine next, so we'll talk all about diabetes coming up, but we'll touch on it briefly here. Now, normally, how do they test for gestational diabetes? Well, they can do the dreaded oral glucose tolerance test. Every person I've ever talked to who has done this has said it's super gross because it's like way too sweet, like sickeningly sweet Gatorade or something. Um, there's a couple different ways you could do it. Some people do like a 2-hour test. Some people do a 2-step method. Yeah, so maybe Allison can speak to that. But yeah, it sounds like it's just real gross, especially if you have to go back and do it a second time. I think my wife had like a borderline level at once, and then she had to go back to do it a second time, and it was just miserable. She hated it. Um, and so basically, you'll, based on the blood sugar levels that come back at different time periods, that can indicate if you're having some issue of glucose homeostasis. I'm not going to get specific into the levels and whatnot because, again, you'll get that in other classes, I imagine. You can also look at things like hemoglobin A1C, can give you an idea of like that 3-month sort of window of their average glucose. Fasting glucose can also be used as well there. But what do we do for these patients? Ideally, no drugs. That's always the goal here, right? So if we can do things like dietary modification, if we can kind of regulate their carbohydrate intake, that can be somewhat useful. But we'll see that in a lot of cases, insulin is probably going to be the drug of choice just because this is the most quote unquote natural thing because that's what their body normally releases anyway. We'll find a lot of the insulin products that we use is not specifically human insulin. It's a little bit of a modified version, but it's very safe to use in pregnancy. Doesn't cross the placenta because insulin's a protein, so it's too big to cross over there, so it doesn't really affect the fetus. Some other things that we've used as well include things like glyburide. This is in a class called the sulfonylureas. This is basically a class of drugs that cause the pancreas to release more insulin. So probably pretty safe. You tend to see hypoglycemia being the biggest risk with sulfonylureas and insulin. So of course you're going to be monitoring for that in the patients. And then metformin has been used as well. That probably lacks nitrogenicity. I don't know if it's like a solid B or not, but it's probably one of those ones where you kind of, again, weighing benefits versus risk. And this one acts as an insulin sensitizer. So it kind of helps at the liver and also at the skeletal muscle to make the insulin that you produce work better and helps to get those sugars under control. So, again, the safest thing to do is probably insulin, although to take insulin, you have to inject yourself, which is not ideal. So if you can fix it with diet, that's going to be A+ for the patient, I think, from a compliance standpoint. So we'll get into way more into diabetes in the next section coming up, so don't worry too much about that. Someone said, typically, what medication is used in the ER for pregnant patients is preeclamptic, labetalol, magnesium. Typically, and again, this has been a while since I've worked in an adult ER, so I may be a little out of practice here. But what I've normally seen is that, at least where I've worked, the OB guys were pretty quick on the scene. Now, granted, this was at a educational institution, so you always had like residents and stuff who were available to come see the patient immediately, and so they kind of took over and kind of sweep them up to the OB floor pretty quickly there. I think if they're really preeclamptic, I've seen most of the time go magnesium first. Yeah, so you probably had Kelly, I imagine your protocols are probably just to go with the mag, and that's probably most common, I would say. Labetalol I would either see as like a backup to the mag or used for one of the chronic management there. So, and again, especially like on the rigs, you're going to be carrying mag for a host of other reasons too. So if they're in cardiac arrest or if they're in torsades, all kinds of things you can use magnesium for, which is handy. I'll probably go mag first in that situation. Okay. So as I mentioned, thromboembolism is a concern here because we do see with increased estrogen expression, the liver is going to be producing more clotting factors. That's just one of the effects of estrogen, as we'll see a little bit later on. And so we don't use warfarin. It's not going to be recommended anymore. And then instead, we would use something like the low molecular weight heparins or unfractionated heparin. Again, those are pretty large molecules, so they can't really cross over and affect the fetus, which is good from that standpoint. The downside is that you're going to see these are injectable only, so this would require the patient to give themselves either once up to 3 times daily injections. Most people will probably started on enoxaparin, which is 1 to 2 times a day, depending on the indication and depending on the provider how they're ordering it. And then usually this is only going to be for patients who have like a high risk history for clots or if they develop a new one. Now, the role of the newer oral anticoagulants like Eliquis and stuff like that, probably, I don't know if we have enough evidence to say whether or not that's safe. I've not looked in that research recently. I know it's getting more accepted for like initial use for like routine DVTs, but again, for pregnant patients, that stuff typically lags behind by a few years until we get enough sort of just kind of passive information on that. We can't really, again, do the clinical trials to figure that out. And then usually they would go ahead and continue treatment at least 6 weeks after delivery, or they need to get to a total of 3 months, depending on when they had the event in the first place. So again, if they're bedridden, that increases their risk. So lots of factors go into that. Someone said, is it possible the medications won't work to lower gestational diabetes? If so, what would happen then? So ultimately, insulin is going to work because, especially if you consider these patients, you could even have like just the worst type 2 diabetic patients in the world. If you give them enough insulin, their blood sugar will drop. There's no degree of insulin resistance so severe that they're not going to respond to it. So you can always give more insulin. So I wouldn't imagine that the drugs would not be effective at some point. It just matters how much you're going to give. But yeah, I've seen some really poorly controlled people that need like just gobstopping amounts of insulin that would kill a typical individual, and that's just what they need because they've developed so much resistance over time. But the topic for another day. So another thing, just a couple smattering of acute conditions with pregnant patients. With UTIs, you always want to treat these, even if they're asymptomatic, because you worry about having, sort of that occult infection sort of affecting the fetus. So things like macrobid or nitrofurantoin is considered a category B. This one I didn't mention too much in the antibiotic section, but this can be used here. This is typically only used for UTIs for the most part. It basically affects the bacterial cell wall to inhibit its synthesis and thus kills off the bacteria. Note that it doesn't cover Proteus, so if your patient did culture that out, you would need to switch them out to something else. Other things we could use include amoxicillin, cephalosporins. All these tend to be fairly safe, and also they can be compatible during breastfeeding as well. It's pretty straightforward there. How about pain? Pain, again, if you can, pain is just weakness leaving the mind. Tell them to suck it up. Buttercup? No, don't tell them that. That'd be really rude. In fact, there's a big history of people, pregnant women especially, being undertreated for pain. So please listen to them when they say they're in pain, okay? Even though your options may be a little bit limited, okay? So looking at this, acetaminophen, super safe, right? Drug of choice for any pain condition. However, it may not be sufficient in a lot of cases, especially if it's more severe pain that you're dealing with, like if a patient's having migraines and things like that. They'll probably laugh at you if you tell them to take some Tylenol for their migraines, right? You could use things like NSAIDs during the first and second trimester relatively safely, but in the third trimester, as I mentioned, can cause that premature closure of the ductus arteriosus, so that would not be good. So that's considered a D at that point, so it would avoid that. And again, how do you close that once a kid's born? You need to close it. You actually just give them IV ibuprofen or indomethacin. You can actually close it for them, as I mentioned previously. If it's even more severe than that, you could use opioids. It's not to say that these are going to have a negative impact on the fetus directly. It's more so that you want to avoid more prolonged use of this. You don't want to have people using this chronically if at all possible, because again, the fetus will be exposed to that opioid and they can develop tolerance and physical dependence just like the adult can. So again, that's where I run into a lot of neonatal abstinence syndrome that you see in the NICU all the time. Who the mom has been exposed to opioids throughout the pregnancy, and then the kid comes out, and all of a sudden they're like, "Where's my opioid at?" They get very cranky and very difficult to feed and regulate their temperature, so it's pretty unfortunate when that happens. So short-term use, relatively safe. You have to use it. For long-term use, it's considered a D at that point because of those reasons there. Other things, so mental health during pregnancy, this is a huge issue. You're going to find that a lot of pregnancies are affected by some degree of psychiatric illness, whether this is anxiety, depression, etc. And as I mentioned, many women just discontinue all treatment because they are concerned about what's going to happen to their fetus. So this is, a big deal to at least talk about and at least address in your patient and ask them about, see if they're experiencing any of these issues. It's easy to write it off as a postpartum blues, but you can find there's really significant depression associated with this, especially if you consider, the hormonal changes that happen after pregnancy. If you look at the estrogen levels and just how they crash after that child's born, it makes sense that they would have, especially the pre-existing issues being exacerbated by this. And so it's really a big concern, and that's why we need to have good public awareness of it. I think is improving, but it could always be better, especially for your providers to be more likely to treat it as well. So SSRIs are going to be the safest out of this group to use for these patients here. They tend to be effective. There, are some evidence to show that you could have some issues in terms of some developmental effects. Although, again, this is really difficult to, there's a lot of bias that goes into some of the studies that come about because, if a woman has a baby that has a congenital effect, it's very easy to look back at, all the stuff that they had happen to them during the pregnancy, but, oh yeah, I took that SSRI, that's probably it. Versus people have normal pregnancies, they don't really think a lot about what happened during that development, right? So there's a lot of recall bias associated with this. Hard to do studies, hard to get really clear evidence on what the risks are associated with this. So again, that's always a challenge, okay? Certainly SSRIs tend to be the safe side of this bunch here. Again, there are possibility for withdrawal effects. This is typically, ameliorated by the fact that if the baby is breastfeeding, that can be helped because the mom is still going to be giving exposure to the child through the breast milk. However, if they're not breastfeeding, then that may be an issue they run into there. But things like citalopram, paroxetine, any of these are fine. I think paroxetine might be the least safe out of the bunch because they have found, 1.2 to 2-fold. It depends on what source you go to. This increased risk for cardiac malformations. Now that sounds scary. It sounds like it's a huge increase, but remember, if your risk for something was 0.5% and it was a 2-fold increase, it would only go up to 1% chance of happening, right? So think of it in context. But I'd probably go with something like fluoxetine or citalopram, probably first line for those cases there. But every provider might be a little different. TCAs could be used as a second line. However, there are going to be more adverse effects associated with it. You'll see, you're going to see adverse effects including like anticholinergic effects, sedation, etc. So if you can use an SSRI, I would go ahead and go with that and use TCA as a second line there. In terms of like fetal development effects, there's not really been much reported. Things like amitriptyline, nortriptyline, those are all fine to use if need be. And then folic acid is quite important for these patients as well. Ideally, the best time to start folic acid for your pregnant patients is before they become pregnant. So even though you have non-pregnant patients, they could still receive prenatal vitamins that is getting enough folic acid for them. They should be getting at least 400 micrograms per day in order to prevent neural tube defects. And so if we could do this, we could prevent a lot of those incidences of neural tube defects from happening. If they have a history of giving birth to an infant with a neural tube defect, they actually recommend even increasing the dose pretty significantly. So we're going from 400 micrograms up to 4 milligrams. So you can see pretty big increase there. They'll do that prior to conception and then throughout the pregnancy. And a lot of women do not follow this recommendation, either not being compliant with prenatal vitamins or in their diet or whatever the case may be. So this is a big recommendation for those patients there. Okay, so let's get into more, let's say, close to the delivery itself. So let's say we have someone who we are worried about the patient going into premature labor. How can we keep that quote unquote bun in the oven for longer? What can we do? Well, that's where we use tocolytic therapy. I think is a fun word to say, tocolytic, tocolysis, if you will. We have a couple things here that help out and help to prevent uterine contractions, basically. They help to relax the uterine smooth muscle to prevent contractions from occurring, basically. And so we have a couple classes here. First off, they're going to be the beta agonists. And basically, we can utilize, just like albuterol is used as a beta 2 agonist to activate the bronchial smooth muscle to relax. We can do the same thing for the uterus. The uterus also has beta 2 receptors that causes smooth muscle relaxation. So an IV form of something similar to albuterol is called terbutaline or breathine. Rarely it's used for asthma, but most of the time you'll see it used in the L&D ward for tocolytic therapy. And basically, Give this, it will relax the smooth muscle and prevent contractions, hopefully. Magnesium may have some limited utility here, but more often than not, what I see for more chronic use, say you show up at your OB-GYN's office and you're complaining of early contractions, they may put you on a calcium channel blocker, because if you recall, calcium channel blockers also relax smooth muscle. And so not just on the vessels, they can do it on the uterus as well. So something like nifedipine is actually pretty often recommended for this, for more chronic use prior to delivery. And so you'll see this done because there's a pretty favorable side effect profile. So that's probably the most common one I've seen, at least in passing. But other calcium channel blockers, other DHPs would probably work just as well. Indomethacin has also been used occasionally, but I don't see this routinely recommended. So if you're worried about bottoming out the patient's pressure, because maybe they have low blood pressure or just at baseline, then this may be useful. But again, I've seen relatively limited cases of that being used. Again, I don't work in OB-GYN every day, so it doesn't mean just because I haven't seen it doesn't mean it doesn't happen. All right, so just take context into consideration, I will say. With progesterone, this is something that is done occasionally. Isabel saying, I thought NSAIDs were category D in the last trimester. Right, that's that risk versus benefit sort of thing there, right? So that's where you got to consider, okay, well, how am I going to be monitoring for this? That's going to definitely be more so, like, I'd probably get like the specialist involved in those cases there. So that's why it's D and not an X, right? Because there could be situations where it's the benefits outweigh the risk. Okay, I'd say that everyone should do it, but I would probably say try a calcium channel blocker first, right? So another thing you can do, I think, is a little bit more controversial in terms of the overall efficacy, but I know at least like I know that like my sister had a history of her first child was born at 33 weeks, I believe. And then, so it was premature. She was premature. She ended up getting pregnant with twins afterwards, which, twins are also more likely to be born early. So she actually ended up getting put on progesterone therapy, and I've seen other women get this as well. But basically, they have a high-risk history of preterm birth. They can actually get IM injections of hydroxyprogesterone. So it's a progesterone-based product, which we're going to get more into in just a little bit here. And it used to have to be like specialty compounded at pharmacies because there was no commercially available product. But now they have a new one, hydroxyprogesterone, that they can use. And of course, now it's a brand name drug, so it also probably costs a lot more. But this could be used to help prevent early labor for these patients here. Now, what if we want to do the opposite and try to get the baby out of the mom? There's drugs we have for that too. So it's important to keep in mind what's a tocolytic versus what will induce labor, right? So Marley was saying, so the progesterone is used more prophylactically. Yes. So that would be, as I mentioned, like, my sister, she was not having early contractions, but because she had a high risk pregnancy beforehand, they went ahead and put her on it for that next pregnancy because they knew she was going to be at risk just due to the multiparity and the previous history of her first birth there. So what point would it start being given from the beginning? I have to look at the dosing recommendations. I'm not sure specifically when they start that. I know this is probably like really boring thing to watch and you're like, why are you searching for stuff in the middle of class? But so here's thing here. Let me pull it up for you guys. So this is hydroxyprogesterone caproate. So it says pregnancy indications preterm birth. Is that McKenna that I mentioned there? See, pregnant females greater than 16. Continue weekly injection. Okay, so begin 16 weeks 0 days and 20 weeks 6 days of gestation. So pretty specific on when to administer there, and continue weekly until 37 or until delivery, whichever comes first. So pretty early on there in terms of that, because you think about like how when a fetus becomes viable, you don't really think much before 24 weeks. So it makes sense you kind of give it at around 20 or so. So pretty interesting. Someone said, would you give progesterone to women who have a history of preterm births, or is a calcium channel blocker enough? And again, I'd also ask Professor Lack, because you might have some perspective on this too. I think if you had a pregnant patient who did not have a high risk history of preterm birth, say it's like her first pregnancy, and they were experiencing contractions, then I'd probably go with the calcium channel blocker. If they have a history of having preterm birth, so they had, say, oh, they have one child that was born at 32 weeks gestational age, then yeah, the progesterone may be good for those repeat instances of pregnancy. So that's what I would say for that. Someone said, would you use chronic use tocolytic therapy if labor occurs super early? It depends, I think, on the situation in terms of, if the patient's trying to go into labor, if like the point where, actually, I don't want to speak out of my depth necessarily, but my understanding is that they're experiencing contractions of the uterus itself. That's where they can utilize things like the calcium channel blockers. Now, there's certain other things that are just like kind of normal contractions. So if you ever hear like Braxton Hicks contractions, that would happen a lot. Like I know at least with my wife, where she would get kind of dehydrated. If she drank enough water, those would kind of help to decrease in frequency. But yeah, I don't want to speak too much out of my depth on that case. Someone says, there limited data on the usefulness of magnesium as a tocolytic, or why is it first line per online sources? I think in the cases for like preeclampsia, it's first line, but as a tocolytic, like I think it depends on the clinical setting. For like long-term chronic use, I probably wouldn't see magnesium being used as often as something like a calcium channel blocker, but it depends on the clinical situation. If they're like in the hospital, then that may be more reasonable to use that, because this is like IV administration of magnesium, not necessarily like PO like you could use with a calcium channel blocker. So yeah, I think the context will depend there in that situation. Just to confirm, did you say CCBs would be first choice for tocolytic therapy? I think, as I mentioned, it depends on the situation. So if they're in the hospital setting, you'd probably see more terbutaline, maybe magnesium. For more like chronic use, you'd see more calcium channel blocker use, because that is probably better tolerated from an adverse effect standpoint. Also if they have like history of preeclampsia, that would also kind of treat that too at the same time, so you can get multiple benefits from that in those situations. Someone said, no, this is totally off subject. Feel free to answer this at the end of class. I'll answer right now. Random thought in regards to pain management lecture. What would make you want to pick Toradol over Tramadol, or vice versa? I would do, so if I had someone coming into like an urgent care or an ER setting, and the route is not an issue, I would just go with Toradol, as long as they don't have any any past medical history that would make me not want to use an NSAID. So like, renal disease or something like that, I'd probably avoid using the Toradol in that situation. Otherwise, Tramadol is more of an oral med that you maybe like send the patient home on potentially. So if they couldn't get Toradol, couldn't get an NSAID, then maybe go with Tramadol at that point. Or maybe like short course use Tramadol if I didn't want to prescribe them like not that I'm prescribing it, but if you did not want to prescribe an opioid, like a full blast opioid like oxycodone, this could be a good alternative there. All right, good question, you guys. I really appreciate your engagement with my content. It's great. Okay, so let's say we want to go ahead and kick labor into high gear. This is basically, we have therapy that can help kind of facilitate the cervical ripening and labor induction process. So a couple of different things we can do. One, we can use our prostaglandin analogs. And so first off, we have dinoprostone or Cervidil. This is actually given vaginally, and you basically sit it at the side of the cervix, and that basically allows the drug to release prostaglandin E2, like an analog of that. And then basically you will leave it there until labor begins, or if it doesn't work, after 12 hours or so. This can cause things like fetal bradycardia, so you're going to be monitoring heart rate anyway for these patients, but that would be one thing you'd want to look out for. With misoprostol or Cytotec, we've talked about this before in terms of its use for NSAID-induced ulcers, but this could be used as an alternative to dinoprostone. Either of these would be fine there. Remember, don't use it too early, because that can cause termination of pregnancy. So notice how these can act as an abortifacient, but when you're ready to induce labor, this is the purpose of them. They can be used for that purpose. Oh, it's funny. Someone said, on that note, as a pharmacist, are you technically allowed to prescribe drugs? No, I'm not. There's like a really limited formulary. It's like something you never ever use, but on a technical basis, I think there's like a very limited use case, but practically no. In certain countries, I think like in the UK, there's like a third tier of medications between prescription and OTC, and druggists or pharmacists could do that, could prescribe from that, but that is not the case here in the US. So no. I make the recommendations and then I make the magic happen when you order it. So other things we can use include oxytocin. This is like that love chemical that makes you that you release when you hug your puppy or hug your kid or whatever the case may be. This is a pretty common one you'll see being used for labor induction. Basically, what you find is that when these pregnant women will be releasing this stuff anyway. But what happens is that during pregnancy, you tend to find that the uterus will have an upregulation of oxytocin receptors, so it becomes more sensitive to the effects of oxytocin, and that allows for it to work even better than it would otherwise. And so this is a natural process that occurs towards towards delivery. And so by giving this exogenously, usually as an IV infusion, that will help to facilitate the contractions in there. There can be some risk associated with it, although it's relatively rare. But you can see things like PVCs and other arrhythmias that can develop, and bleeding risk due to afibrogenemia. Fibrogenonemia. It's a hard word to say. Don't repeat that after me. Afibrogenemia. There you go. Again, that was also probably poor, but whatever. You get the point. You have low fibrinogen levels. How about that? At the end of the day, I was doing interviews all day, so I get kind of mushy mouth after a while. But see, someone had a question. Someone said, can dinoprostone cause abortion if given early? I think it's only available vaginally, so I think the situation you'd run into where that would occur would be exceedingly rare. But technically, I guess it could if you kind of cause the cervix to ripen too early. So yeah, I would not do that for your patients there. But again, how you would accidentally do that would be unlikely, but I guess if you did it intentionally. Yeah, I really want to see either a suppository or like a vaginal gel. Yeah, so I would not be too concerned about that because you're really only going to be using it, because like misoprostol you can get like orally, you can get, people can have it at home, they could take, but something like this would be used more so like directly in the hospital. Like a patient would not be giving it themselves out in the wild, so to speak. I've heard a lot of women don't like the idea of being given Pitocin, which is oxytocin. But if it's technically a naturally occurring thing in the body, why do you think people don't want it? I don't know. I think there's a lot of things that go into it. I think it's if people want to quote unquote do it naturally and do it on their own, that's perfectly within their right. I don't know if it's hard to say. There's a million different reasons why people make those decisions. And again, you're already in a charged environment in the first place, just because there's a lot of emotions going on, and it's it can be chaotic at times. At least my experience is there's moments of chaos and then utter boredom as you're waiting for things to happen. But a lot of reasons why people may decide to do that. And if they decide that's the way they want to do it, that's totally fine. Just like people, giving epidurals for pain, it does have its risk, but it's still relatively safe. Some people don't want to do it. It's okay, to each their own, I say. As long as it's not actively harmful, that would not be good. But looking at labor pain management, this is most often administered as the epidural infusion. You'll end up seeing that it'll be a combination of an opioid like fentanyl plus a local anesthetic, bupivacaine. That combination is most frequently done. Allison's saying could be possible the mom doesn't know Pitocin is naturally occurring. Oh yeah, it's very true. Yeah, that's a very good point there. I think not and that could be a way that you could educate them and explain to them that hey, this is something you produce anyway. We're just giving you a little extra dose of it. Oh, sorry. Yeah, we're just giving like a little bit of an extra bit of the naturally occurring hormone you're making anyway. Just like insulin, if you're taking regular insulin, that's human insulin. That's the same stuff that you produce anyway. But so yeah, good point, Allison. Thank you. Anyway, so as I mentioned, so the epidural is typically the fentanyl, it's the most frequent one I've seen, and then bupivacaine or ropivacaine, some sort of cane drug on there as a combination. So the benefit to this is that with epidurally administered drugs, they only work kind of at the level that they're sitting within the spinal column. So if you are sitting upright, it's going to tend to settle down at the bottom, and so the anesthesia that it induces is going to be at the lower portions of the body, right? So ideally, you just really need them to be numb from sort of like the belly down, because that's where all the pain is occurring there. But certainly by positioning the patient differently, that can affect how high it's going to be going up and how high the patient may be affected. There's cases where all of a sudden they can't feel their fingers or they can't move their fingers. That could be a sign they're getting either too much or their position is such that it's traveling up too high. And then other things you can run into include things like hypotension from the medications. They can develop pruritus, so sometimes you have to treat with like some antihistamines. Most of the time, these patients are going to be numb enough to where they don't really feel the need to void necessarily, but they'll oftentimes be have a urinary catheter in place. So this is usually not a big problem until like maybe after the pregnancy. And once the drugs have been stopped, sometimes they can have some challenges voiding afterwards. And then two, think about it as well, that pain that they're experiencing is also, humans are naturally avoidant to pain. So you typically want to get whatever's causing you pain over with. But if you numb that or if you dull that pain, then sometimes it can prolong the sort of first and second stages. If you're feeling less pressure, less pain, they may be not pushing as hard or they may not be able to. The other big thing you'll see too is spinal headaches that can occur. And this is actually due to the physical penetration of the subarachnoid tissues as that needle goes in. So if they have like a headache in the next couple of days, that's probably related to the anesthesia they got during the pregnancy. So let's see here. Another question, would different methods of epidural be used in C-section versus vaginal, or C-section a whole different process when it comes to that? Sorry, I'm getting ahead. No problem getting ahead. As far as I know, I think it's fairly similar, but you may change how much you're giving. Obviously, the patient is still kept conscious during a C-section. I've not been party to a whole lot of them, and again, a lot of my experiences either come from personal experiences, not my pregnancies, but my wife's. Or just what I've happened to see. I've not been present for a C-section before, so I could not say necessarily on that process. And again, I work at a kids hospital, so we don't deliver any babies, or if we do, if they're getting a C-section at Nemours, things have gone horribly wrong. So I can't speak to that necessarily. But if you look up some, if you go to Up to Date, you can find kind of like standard articles on anesthesia during like a C-section and different obstetric indications, and it can give you some clues of how you would change these things up a little bit. So yeah. Let's see. I've had 3 come talk to me about it. It's funny. Yeah, my wife's had 2 of them. And it's funny because, as I mentioned, I may have mentioned the story, but my wife had kind of marginal blood pressure while on the epidural, and I was like, I don't know about that blood pressure. It looks kind of low. And she's like, if you tell them to turn down this medication, I will have enough sensation in my legs that I can jump over there and strangle you. So I remained quiet for quite a while after that. So I think that was probably a good choice in my brain. Some said, what would be causing the pruritus with the epidural? I thought fentanyl didn't cause pruritus since it's synthetic. Yeah, typically it doesn't cause a whole lot of, it doesn't cause histamine release like morphine does. But certainly like the bupivacaine itself may cause a little bit of the pruritus. It's just something you can see with it. So it's not as bad as like a morphine might for someone who's susceptible to that. It's just something we notice as occurring. And some said in the PD lab, why couldn't we give the patient with pancreatitis Toradol or Tramadol for pain instead of morphine? So let me get back to that in just a second. I think I'm going to cut it there because I can finish this up in the next section, and then we'll have our review on Friday. So I think I have enough time. So I'm feeling confident about that. Notice my hesitation, but I'm going to leave it there. So I'm going to go ahead and say that's it for the day. But back to your question. Someone said in the PD lab, why couldn't we give a patient with pancreatitis Toradol or Tramadol for pain instead of morphine? I think when you consider, why that patient's there, think about things like what could the patient be heading towards, right? So if they have pancreatitis, is surgery in their future? Maybe, maybe not, right? In that case there, giving them something that can increase bleeding risk may not be the best idea. So maybe you want to avoid Toradol. Most people will probably end up getting some Toradol, but you could consider that. I think Tramadol is not going to be sufficient for someone who's presenting for like severe belly pain. That's kind of too weak, so I would probably err on the side of like a Toradol. And if you need some morphine, they'll probably end up needing that regardless. That's fine. Fentanyl's fine. Dilaudid's fine. Any of those are fine as long as you get kind of an equivalent dose. So hope that makes some sense. Okay, so yeah, that kind of blazed by pretty quick there. What other questions can I answer for you all? Hopefully that makes a sense. Hopefully it kind of comports with what your experiences are. If not, let me know. I'd always like to get more perspectives on things. Patient with diabetics that would make controlling sugar worse. No. So with that, if you're concerned about the patient being diabetic, you think about renal function. So if they have if they told me I have a history of type 2 diabetes, I would be checking their renal function before giving the Toradol. Because if they have existing kidney disease, that could acutely worsen that. Now that you mentioned that, Kaylee, thank you. That does make sense of why we're trying to avoid Toradol. So tramadol would be, you can get that safely for those patients, but I think for that amount of pain the patient was experiencing, tramadol would not touch it, right? Notice it's easy to mix up these drug names here. It's easy to get confused sometimes, but tramadol would probably not touch it. That's really an oral only medication for the most part, so that's why I go something IV like morphine, fentanyl, etc. Oh, no problem. I don't mind answering your questions at all. I take any and all questions, whether they're on topic or not, although I reserve the right to refuse answering them. Yeah, no problem. You guys have a good one. I will see you all at bright and early 8 o'clock in the morning. Hope you all can not run into too much traffic to get here, but I'll see you then.